and outcome in post-cochlear implanted patients. So without further ado, I would like to invite Prof. Juanita to conduct the workshop.
Thank you very much, Dr. Jeriza. I'd also like to thank the organizers for inviting me to talk today. Now, I hope my lecture will explain a little bit about the questions which I have heard being asked at the previous talks. So explain about anxiety, ADHD, and as well as the role of medication. I'm not going to touch so much about mood problems. The main mood problem which you get in children with autism spectrum disorder or ASD is depression, and that's often seen in the older children, the adolescents and the adults. So I'll start off with definitions, and then after that treatment and a little bit about medication as well. And then we'll have some case illustrations, so to put everything in context. And then after that, I think we can have a discussion, and I'd be happy if you take part as well, on whether, how useful it is and how important it is to make many diagnoses, whether we should talk about a child having ASD, OCD, or ADHD as well, or whether we should just say the child has ASD and describe their problems, because sometimes I think it can be very confusing if we have multiple diagnoses. Okay, so why should we identify children with autism who have attention and anxiety difficulties? Well, if you do have these problems, it can interfere with everyday function. So it will interfere with learning. If you cannot pay attention, it's very hard to learn. Interfere with completing tasks. Socializing, again, if you're anxious and you do not want to be put into a social situation, it's very difficult to socialize. Sleep is an often ignored problem, okay? And children with anxiety, they might, especially the children who are not very verbal, they might be presenting with sleep problems, and actually they're anxious. Yeah. And the anxiety's not been identified. Eating difficulties, so we have children who are very picky eaters. You might be asking, what does that have to do with anxiety? Well, there's a component of anxiety. They just don't want to eat the certain foods with different textures, and they get very anxious when they're in situations where they're forced to eat different types of foods. Okay, and it'll also interfere with other activities of daily living. And in my case illustrations, I'm going to talk about 1 or 2 cases of phobias. So what is anxiety? Anxiety is a normal response to a stressful situation. And I think all of those who are parents will have felt this at one point or another when their child's going to the first day of school or kindergarten. Yeah, and there are some physiological responses which one gets when one's anxious, so your heart might beat a bit faster. But there are good things with anxiety as well, because it makes you more alert. However, it becomes a disorder if you cannot control your anxiety, okay? Or if it's very excessive, so much so that it interferes with your activities of daily living and your day-to-day lives, okay? Some examples of anxiety disorders are separation anxiety. So separation anxiety, we can see that in children when they start kindergarten, okay? It's quite normal for most children starting kindergarten to be upset. But if that upset distress becomes excessive, so much so that some children, they take 6 months or more to transition into kindergarten, well, that starts to become a disorder. And as you know, many children with ASD might actually have that problem, separating from the parents. Okay, selective mutism. Selective mutism is when the child might speak only in certain situations. Yeah. So let's say they might speak at home, but they might not speak at all at school. Okay. Again, not uncommon in children with ASD. Yeah. Phobias. Agoraphobia is not wanting to be out in the public places. Aviophobia, afraid of flying. So these are all examples of anxiety disorders. Yeah. Obsessive compulsive disorders. That's another group of problems which have a lot of anxiety features as well, okay? And the key thing about OCD, obsessive compulsive disorders, is the person has a lot of negative preoccupations. So let's say they feel that there are germs everywhere, so they don't want to touch things, and they're always washing their hands, washing. They might have to wash their hands several times before they go on to the next activity, okay? There might be other sorts of preoccupations, such as like needing to count the tiles before going out of a room, yeah? And they will only feel relieved, they feel anxious if they don't get to do that ritual, washing their hand or counting their tiles. And once they do that ritual, then they feel better, but then the preoccupation will come back. So maybe 5-10 minutes later, they'll start thinking about germs again. Okay? Now, so you have an idea what anxiety means, anxiety disorder means, and OCD means, obsessive compulsive disorder means. So do children with ASD have anxiety and obsessive compulsive problems? Absolutely, because if you think about it and you go back to the definition of ASD, problems with social emotional reciprocity and developing relationships, yeah? Insistence on sameness, routines, and rituals. So if you have a child who has difficulty socializing and you put them in a social situation, they're going to feel anxious, yeah? If you have a child who has the need for sameness and rigidities and stereotypical movements and rituals, and you try and stop it, then they're going to feel anxious as well, yeah? And sometimes all these rituals can interfere with activity of daily living, yeah? Okay, so from a research point of view, how many children with ASD, or what is the proportion of children with ASD have enough of anxiety problems to say it's very significant, yeah? So it's estimated 25 to 55% of children and adolescents will have this above problems. If you look at research, and it's because of the tools we use to measure anxiety, it looks like more children with mild ASD have that problem. But there is some evidence that it's because of the tools we use, which are often questionnaires which we give to parents and in children who can read and who are highly functioning, they can answer the questionnaire themselves. But actually, we think this is an underestimate, okay, this 25 to 55%, because we also know that children with more severe or moderate to severe ASD, yes, sorry. Oh, you can't hear, okay. So we know children with more moderate to severe problems can also have anxiety. Okay, and how do we diagnose it? History is very important, and I'll talk a bit about the symptoms. But from a health professional view, we do use parent questionnaires. Okay, and the one which is commonly used in Malaysia is the child behavior checklist. It's easy to fill in. It's about 100 questions. It's been translated to Malay. We've done some research on it, and it's valid. Okay, to be used in Malaysia. It's been translated Malay, and also there's Chinese version. Okay. So how do we identify anxiety and OCD symptoms? How do the children present? And that depends very much on the age and overall intellectual level. So children who are milder might actually tell you, I don't want to go to school, I'm scared, and they might have lots of preoccupations, such as like, I'm afraid to go to school, the teacher's very fierce, things like that. Or they might have phobias, yeah, and they can express it. Children who are moderate to severe, it might not be so straightforward, okay? And they often present with behavior problems. So temper tantrums, increasing in their restricted repetitive behaviors, so more stimming, might have increase in self-injury as well. And of course, as I mentioned before, sleep difficulties. So, okay, we know that this child's anxious, but part of our assessment is also looking for triggers, okay? So, look, when do those behaviors manifest? Is it when there's a change in routine? So some lesson gets cancelled, okay? Is it where there's a change in environment, okay? New school, of course, is always the big one, the transitions, yeah? Unfamiliar social situations such as parties can be very difficult, okay? are there sensory issues which are causing anxiety? So we know children with ASD may have sensory defensiveness, yeah? There's certain things which they don't like, certain noises, maybe lights, yeah? So try and identify those, okay? Fear of a particular situation. You know, school toilets are always a big, big thing, but you know, okay, I have to admit sometimes I'm afraid to go into some of the school toilets because they can be a bit scary, but it's a particular big thing, I think, with many of our children. Okay. Now, so we know that the problem is there, anxiety is there, so how do we decrease it? And one very important first step is actually getting the child to identify in themselves when they feel anxious. And there are lots of visual scales you can use, or visual aids. So these are just very simple, you know, smiley faces and so on to identify emotions. You can get the child to draw, you know, when you feel anxious, you know, what is it like? Can you draw it, you know? And some children are very, very good at drawing and can express themselves through drawing. There are so many things on the internet. This is Sesame Street, and again, you know, all the different expressions and emotions. Okay, I'll talk about that later. And once they can identify when they are feeling anxious, we can teach them how to cope and all the different techniques we can use. So one very simple thing is just deep breathing. Deep breathing, and this video, I am afraid I couldn't download the video, but this is a very nice video on teaching children, and who are minimally verbal as well, on how to deep breathe. And this was actually shown to me by a parent, and it worked very well for her child. So you can look up that video. There's an app which can go onto your phone. Okay, counting to 10. Some children find actually doing a lot of physical activity can be in some ways calming and reducing their anxiety. So jumping on a trampoline, okay? We also want to promote coping skills. So if there's a particular situation, let's say going to the doctor, which the child's particularly terrified about, you can go through rehearsals, yeah? So maybe take the child to the hospital first, but not go into the doctor's room. So once they're more familiar with the situation, and we just guide them through what's expected of them, you can find the anxiety levels decrease quite a bit. Yeah? Desensitization, I will discuss that in our case illustration. Social stories, I think most of the therapists and parents here know about social stories. Social stories are just basically illustrated, most of them are illustrated stories of different social situations. Yeah? So maybe you could introduce that before going through the full-blown rehearsal for certain situations which cause anxiety in each child, okay? Modifying environment, very important. As I said, look for the trigger, and if it's possible to remove it, then remove it. So things like the sensory type triggers. If it's not important, not necessary, you know, try and remove it, okay? Medication I'll talk about in a bit. So how can we tackle if there are certain sensory issues which may be disturbing the child? Well, some children find having input through a different sensation, they can actually find that calming, okay? So some children find vibrating things calming, okay? So there are lots of toys which are available. You can search on the net. So vibrating soft toy. There's one which I've seen before, which is a vibrating egg. You can just hold it in the hand, and just the transmission of the different sensations may calm the child. But the thing about all these sensory methods is you need it needs to be individualized. Okay, not all children are different, and each child might find something different calming them. Yeah. So this slow motion lamp. Some children find that calming. Okay, the thing about these kind of things like this lamp, we don't want to make the child too focused on it, yeah? You just want to use it to calm the child down so they're less anxious. We don't want it to become a obsession, okay? Weighted items, we see a lot of that, but I have to say in our society it's very hot, so it doesn't work so well unless unless maybe for sleeping in an air-conditioned room. Yeah, we had a child with a lot of self-injurious behavior, and they tried the weighted vests and things, but it's just too hot, to cope. Okay. Now, the Wilbarger brushing protocol, there's not much evidence. I don't know if people have heard about it before. Brushing, that there's a certain technique of brushing a certain way, and you need to do it 2-3 times a day. From a research point of view, there's not much research been done on it, but certainly some children, as I said, they seem to respond to the brushing. They find it calming, brushing, massage. Okay, medication. Now, medication has been extrapolated from adults and children who don't have ASD but have anxiety disorders. And this group of medicines called serotonin-specific reuptake inhibitors, originally being used for depression, has been used in anxiety in children without and adults without ASD, and showed to work for anxiety problems. Okay, but in in ASD, they don't work as well. Okay, and actually, there's a big Cochrane review recently. Looking at all the different studies using SSRIs for anxiety in children with ASD. And the evidence is not that strong. It seems to help some children, okay, but as a whole, not that strong, okay? There's actually a lot more evidence supporting cognitive behavior therapy, yeah? Now, there are other things, alternative and complementary type medicines, such as fish oil and vitamins. For anxiety per se, again, there's not much evidence that it works. Okay, but certainly alternative things like, as I said, massage. That can be calming. Different sensory inputs. Okay, so just to illustrate, I've got 2 cases. Okay, this is a 5.5-year-old boy with autism, and his main problem, we referred him to our psychology team, was he was having a lot of self-injury and temper tantrums. He's actually an able child. His nonverbal cognitive performance was in the average range, and he had quite good verbal ability, and he was in mainstream kindergarten, but his behavior was hampering his progress and causing a lot of disruption at home. Yeah? If he didn't get his way, or if you asked him to do something he didn't want to, a lot of head banging, kicking the wall, and there was this phobia about brushing his teeth. So much so if he sees a toothbrush, he would have a tantrum or scream or cry. And in fact, mother just stopped brushing his teeth, and he had terrible caries. Okay. So this is one of the tools which our psychology team, who are here today as well, used, which is the motivation assessment scale. It's just a quick questionnaire, easy to answer, and basically this helps decide what of these groups are the main problems, okay? And you rank it. So 1 is tangible. Tangible is something, it's an activity which the child wants to avoid, or it's an object which the child wants to avoid. So in this case, it's a toothbrush. Or is it escape? Sorry, escape is an activity which the child might want to avoid, so that was ranked 2. Sensory, was it more sensory problems? That's ranked 3. Or was it more attention seeking? Okay, so you rank which are the most prominent problems. So number 1 would be the most prominent problem, okay? Number 2 would be the second most prominent problem. And so we can tackle things in order, yeah. So Miss Eunice and her team tackled 1 and 2 first, okay? So for him, it was the toothbrush phobia. And also, we found that he was watching a lot of TV as well, okay? And if you wanted him to do something else, he would get very angry, because his preoccupation was with TV and Mr. Bean, and he was copying a lot of the behaviors as well. And so he wanted to escape from doing other things because he wanted to watch TV. He had lack of play and leisure skills, and he also couldn't contain his emotions. He couldn't regulate his emotions, yeah? He would have all those temper tantrums because he couldn't regulate his emotions. So there was about there were 8 sessions or so where he was taught more play skills, so he had more leisure time and play instead of just watching TV. Parents were taught how to give a token system for his good behavior. There was a desensitization program for the fears about the toothbrush. So we first got him to just play with the toothbrush, brush the teddy bear's teeth, and then, put the toothbrush near his lips and then into his mouth, and then brush his teeth without toothpaste, with toothpaste. And we found 6 to 8 sessions, and with the parents as well, understanding his behavior, that actually reduced a lot of the temper tantrums and self-injurious behavior, and he was able to brush his teeth, which is important. Okay, the next child, MF, who's 8, with ASD, he was diagnosed late. Okay, he was diagnosed just before going into Standard 1. Okay, Standard 1 is just before 7. Because although he had a background of speech and language delay, that improved, and he actually had enough school readiness skills. So he was able to read, he was able to spell, he was able to do a bit of math before going into Standard 1. But when he went into Standard 1, towards the end of Standard 1, he had a lot of problems coping in a mainstream school. We referred him to the psychology team because of lots of behavioral problems in the mainstream class. Especially, they managed to get by in Standard 1 because he had a lot of abilities. So from an academic point of view, he did very well, okay? But in Standard 2, when the work became more difficult, so Standard 2 is the age where the child becomes 8, when the work became more difficult, there was a lot of behavioral issues. He would be screaming and crying a lot and having tantrums in class. And parents were under a lot of pressure to remove him from mainstream school, even though he actually had good academic skills, yeah? So he had no friends, he was teased a lot, he would walk around the class and disrupt the class. There was a little bit of corporal punishment as well, if his tantrums went on too long, okay? And although initially he did well, his academics started to deteriorate quite a bit. Okay, so if you look at him, he had his nonverbal IQ was within. If you look at perceptual reasoning, that's the nonverbal bit of his IQ was within average to above average. Yeah, so that's really good. And he had a lot of problems in his verbal areas. Yeah, so and this is the CBCL I talked about previously, the Child Behavior Checklist. And you see there's a section here for anxious and depressed, yeah? So you found this is the teacher's form. So she felt he had quite a lot of anxiety problems and social problems and attention problems is here, okay? Compared to the parents felt he had a little bit of anxiety problems, not that many social problems. But you can see just from this questionnaire that it's school, isn't it? The whole school environment which is causing a lot of stress for him, yeah? But also he did have a lot of behavioral issues at home, okay? He would have several tantrums a day where he'll cry and scream, usually when mother wanted him to do another activity, when he was doing an activity he likes, and then he had to do another activity. And we use, this is called the ABC, the antecedent, behavior, and consequence chart, which we got mother to fill in. So antecedent is what occurred before the challenging behavior began. Behavior is what was the behavior, which, the challenging behavior which happened. What happened after the behavior, which is the consequence. How long did that behavior last? And what was happening at that time. He was playing computer games, it was after taekwondo class. And as I said, we found that a lot of it was when he was asked to do activity which he didn't like, or it was something which he couldn't get, yeah? Or, some of it was attention as well, getting attention seeking. Yeah, so here, he started to cry when mom asked him to take a shower. He started to cry when he was playing computer games and mum asked him to do something else. But his temper tantrums were quite loud. They would cry, although there wasn't much self-injury. Okay, this one here is attention seeking. His father and his sister were watching birds and he started crying because he was being ignored. Yeah. Okay, I'll finish that. Okay. This slide just expresses what I was mentioning before. Is it a tangible problem? Is it a sensory problem? Or is it escape? Or is it to get attention? So we can categorize the problem which is causing the behavior. Yeah. Okay. So, you know, we've identified the behavior. We've identified what coping skills can or cannot be, how to help the child. But we also need to look at the general other skills. So things like adaptive skills. So a child, like this child, MF, he was finding the work a lot more difficult. So we need to help him in the work, okay? It was making him anxious, yeah? So extra tuition classes, okay? Socializing was a problem, so he was entered into a social skills training program, yeah? Family dynamics, so teaching the child. These parents, they were really lovely, but they often gave in to him, okay? So it's important to have boundaries and reward good behavior. Sensory, I've talked about. Cognitive, I've talked about. And it's also important to look at other things like bullying, whether there's corporal punishment as well. I think that can be very negative, yeah, and cause a lot of anxiety. Now, I don't have much time. I was originally told I had 1 hour, okay? So the intervention for him was communication and speech, increase the play and leisure skills. I'll just give you an example. So for him, these are some pictures. We asked him to draw pictures of emotions, and these are his drawings, okay? Visual aids on how to recognize emotions, yeah? And these are the things. You recognize emotions, but you also want him to understand why he feels that way. So this girl is scared. Why is he scared? And you see he drew something about a nightmare. Yeah. Okay. And then we give them something like a multiple choice. Okay. So she feels happy. What do you do when you're happy and you've received a present? Well, you can thank your mother. Okay. He feels his toy is broken. What can he do? You know. So we give them methods, you know, and things like multiple choice sometimes can be easier than just asking them to come up with himself, you know, think what you can do. Okay. So the other thing, this is almost like a social story. He was actually verbal, very verbal, but sometimes he ended up screaming a lot and crying when he's having these tantrums, and we teach them how you can use your words to express yourself, yeah? Because he actually did have the words, it's just that he wasn't using them. So for him, you can see his frequency of meltdowns decreased quite a bit, yeah, after going through cognitive behavioral therapy. Okay, I told Mom I have to put this out because after a year or so, his academic results were very good and he's coping well now in the mainstream school, not that many friends, and he actually won prizes at the end of the year, and the teachers have stopped pushing the parents, asking to take him out, so that's we're all very happy. Okay, ADHD, now about ASD and attention deficit hyperactivity disorder. Okay, hyperactivity and inattention also have long been noted to be features of ASD, and if you look at some of the checklists which we use to help us diagnose autism, such as the CARS, the Childhood Autism Rating Scale, there's actually sections on hyperactivity there, okay? And Dr. Ranjini previously explained how we didn't usually make the comorbid diagnosis, okay, but we can do now. And again, it's common, children with ASD, 50% of them actually will fulfill the criteria for ADHD as well, okay? There's some genetic overlap. You heard Dr. Sheikh talk about genetic polymorphism, so different variations in genes, and we find that there can be some overlap in genes which are common to ASD and ADHD as well. If you do MRI or imaging studies, there are some areas of the brain which are noted to be either a bit smaller, usually a bit smaller, which again are common in both ASD and ADHD. Okay, and one important thing as well is children who fulfill the criteria for both ASD and ADHD, they are at greater risk of other mental health problems such as anxiety and depression. Okay, what is ADHD? Okay, so ADHD is not, there are two subtypes. There's just the ADD type, the attention deficit type, and there's the attention deficit and hyperactivity type, so which you fulfill both of the criteria. So you have inattention and hyperactivity and impulsivity. So the child has a very short attention span, is easily distracted, makes a lot of careless mistakes, appears very forgetful, and that's because they're not paying attention to what's being said to them, even though they might understand. Okay? They cannot complete tasks, having difficulty to carry out instructions, again because they're not attending, not being able to concentrate, and always changing from activity to activity. Hyperactivity and impulsivity in a child, so they're unable to sit still, always fidgeting, talking a lot, lots of physical movements. And the impulsivity bit is unable to wait for their turn, acts without thinking, not afraid of danger. But one thing which is very important, which I put down here in red, is that these features must be in excess, must be below that of their developmental age. So let's say if we have a child with ASD who is 7, whose developmental age is 5, okay, and the attention levels, and actually there are ways of assessing attention, okay? There are actually standardized methods of assessing attention. If you find that their attention levels are at a 5-year-old and their developmental age is at a 5-year-old as well, we're not going to make a diagnosis of ADHD, okay? We'll make a diagnosis of ADHD if their attention levels are below that of their developmental age, okay? I hope that's clear, but please ask later to clarify, okay? And I like showing parents this chart because I think sometimes parents, and we all get really confused because there seem to be all these, diagnoses. And the thing about many of these developmental behavioral problems is sometimes there's overlap, okay? There might be a child who's clear-cut, but there might be some children with features of both, yeah? So including things like language disorder, there might be a lot of overlap. Okay, so how do we identify ADHD features? Well, clinical observation, yeah. There are standardized questionnaires, so we often use the Conners, and the Conners, there's a long form, there's a short form. The child needs to present in more than one situation, okay? So they have these attention and hyperactivity problems, not just, let's say, in school or during learning. It's got to be in more than one situation, yeah? So we get the parents and the teachers to fill it in, okay? Now, these questionnaires were used for children who just have ADHD and not other problems, yeah? But actually, there have been other tools which have been developed specifically for children with ASD, looking at more attention problems. So the multi-dimensional scale for PDD and ADHD and the social communication questionnaire will address attention problems as well. Okay. Now, methods to improve attention training techniques. I'm sure many of you can know all this here. So rewarding if you are completing tasks at times. So you set the child a task which they can complete in 5 minutes, okay? And you reward them for 1 week. Next week, increase the time to 7 minutes, yeah? And then reward them. You can use things like alarm clock, so you can't get, you have to stay here and finish this task and don't get up until the alarm clock rings, yeah? Always remember to give short, clear instructions, because remember, very long instructions, the child's not going to listen. They can't pay attention to listen to the clear instructions. Break tasks up into small bits. Visual schedules, you've seen lots of examples of that. Example of a visual schedule. Very important to promote communication. I should have added communication, not just language. Communication, language, and social interaction. Because if a child cannot communicate or doesn't understand what you're trying to say, they're not going to pay attention to you. If they cannot engage with you, they're not going to pay attention to you. Yeah? I've talked about sensory and modifying the environment. Keep healthy. That's very, very important. Okay, minimize things like caffeine. Caffeine is a stimulant, okay, and it can bring out your hyperactivity and inattention. Yeah, have a balanced diet and sleep. Make sure the child has enough sleep, because if you don't sleep enough, you will have problems with attention. Does medication help? Yes, in some cases. Okay, quite a lot of research has been done on using the most common medication is methylphenidate. Okay, it's a stimulant. Atomoxetine is another one which you might have heard of as well. And they are medications which have been used in children with pure ADHD, but they've been shown to work in some children with ASD as well. More the children with the milder ASDs. Yeah. However, the side effects are greater. And in fact, Dr. Ranjini did a study when she was with us in UKM, and of all our children with ASD and ADHD who were on medication, 30% of parents just stopped it in a very short space of time because they felt there were more side effects, either becoming zombie-like, sometimes paradoxical aggression. That can happen, okay? And the effect of the medication is not as great as for those with just pure ADHD, okay? So there was a question yesterday about how doctors seem to be prescribing a lot more medication, but I'd like to reassure parents that we don't just prescribe it just like that. We look at the overall picture of the child, we discuss with the parents as well, okay, before we decide whether to start or not. And it's very important to monitor, okay? So after you start the medication, we want to make sure that whether it's made an effect or not, okay? Because if it's not, then, discontinue it. Yeah? So I'll show you an example how we can monitor it, okay? One quick slide on neurofeedback, because maybe some people have heard about this. There's research being done, quite a lot of research being done about this. Okay, neurofeedback is when research has been done in ADHD individuals about how their brain waves are not as positive compared to typically developing adults or children, okay? And the whole idea is to make the brain waves, and they measure the brain waves using electroencephalograms. So electroencephalograms, or EEG, is a way of monitoring the electrical activity of the brain, okay? And what happens is, they're just like little electrodes, like, when you have an echocardiogram, but it's stuck on the head, the brain, yeah? And, sorry, the head, not the brain. And what's done is, certain videos are shown to the individual, and the videos which the individual produces positive brain waves, the individual will be rewarded if the positive brain waves appear, yeah? Okay? So they pick mainly videos which produce positive brain waves, and the individual is rewarded. And the hope is that if they're always producing more positive brain waves, then that might improve attention. And some studies, it's mixed, the evidence is mixed, has shown that in individuals with pure ADHD, that it works. Okay, for ASD and ADHD, not so much evidence for that, okay, for the moment. There have been a few studies, and it doesn't quite show the positive results it shows in ADHD, pure ADHD. Okay, so this is what neurofeedback is. So showing video, these are the kind of electrodes, and that's the brainwave monitoring. And what you want to do is promote a lot of positive brainwaves. Okay, so quick case study. Katie, 6-year-old child with ASD. He had some language, mainly for requesting. He stayed with his father on top of a coffee shop. Okay, his father and his father's siblings, they're all young adults, ran the coffee shop. Okay, the parents were separated. There were no other children in that where he stayed. The main concerns of father and the early intervention center where he went to was he had real problems with hyperactivity. You know, the consultation, we had a 45-minute consultation, and all of us were like, oh, hair all over the place, sweating, and he had run out and disappeared in the hospital. You know, in that 45 minutes, all that happened. But what we found out was he was drinking. They lived on top of a coffee shop. They ran a coffee shop. There was always coffee boiling. He drank several cups of coffee a day. And so I like to talk about this to the junior doctors because history is so important. History is very, very important. So simple things, stopping the caffeine, the excess caffeine, helped. Okay. Another one, KS, who's 7 years and 3 months with ASD. Lots of hyperactive and inattention problems. Some language comprehension difficulties, although he was verbal. Not able to complete his homework. And social difficulties as well. Being teased a lot, and he didn't know how to play with his peers. Okay. Again, you can see he's lots of strengths. His nonverbal IQ was within the normal limits, and he was going to a mainstream school. Okay. He, after discussion with his parents, we decided that his attention and hyperactivity was a lot worse than his overall developmental level. So we decided to start methylphenidate, a smallish dose. We encouraged to go back to speech and language pathology because they had stopped. A school visit was made, counseling of parents as well about management of his behavior. And this is one way, as I said, we can monitor progress, yeah? And the red line was his corners. This is the corners, this is the questionnaire from the teacher. And you can see the red one was before medication, which in the dark bit, especially here, it shows high levels of inattention and hyperactivity. But after medication and all those other therapies, so not just medication, remember the school visit and all coping about his behavior, much better. Yeah, the scores are below the dark line. Okay, so very important to monitor progress. Okay, so last few slides. Should we make multiple diagnoses? Okay, so I mean, how do parents feel that the doctor telling them, your child has ASD, OCD, ADHD, AD, anxiety disorder? These are all reactions which parents have had to me before. Okay, just complete confusion, or and some parents say, well, what's the doctor saying? How come with so many problems? Yeah, the doctor doesn't know how to make a diagnosis. Yeah, okay, in my personal practice, I feel that sometimes multiple diagnoses can be confusing, and so I like to actually, ASD is the main diagnosis, and then list the problems and tackle all the problems. And the other problem about making too many diagnoses is there might be too much emphasis on one thing, okay? So, like, sometimes if ADHD becomes a big issue, okay? When it's not necessarily just ADHD, which is causing inattention problems. And I just want to quickly show you a video of this child. This child is 4. He's got severe, he's on the severe end of the spectrum. We're trying to get his attention to do the development assessment. So we want to do some turn taking. Okay. He's gone to look at a fan. He's quite preoccupied with fans. So he's very, very minimal eye contact. Trying to get his attention to do a development assessment, and you can see that he wasn't attending. So does he have ADHD? Well, I think there are so many things which were happening there, okay? He had his understanding, his verbal and non-verbal communication. He didn't quite have it. He didn't understand what the assessor wanted to do. He had problems with social interaction. He couldn't engage with the examiner. He had, he had some preoccupations, restricted interests. He wanted to go and look at a fan. Okay, so we can't just say this is ADHD. There's so many things which we need to always look at and tackle. So a holistic approach to problems. So I won't. Depression again, mainly in the adolescent age group and the older age group. Something you need to look out for. Depression, children with ASD and depression, or adolescents with ASD and depression, SSRIs, this group of medication can help, okay? So that is something to look out for. And just one more slide, just for everybody's information about medications we might use in children with ASD. The the antipsychotics. So antipsychotics are medications which originally used in adults, but have been shown to work as well in children with ASD, mainly those with a lot of self-injurious behavior, irritability, aggression. Yeah. So these are other medication which you might hear of and might sometimes be used. So the one in Malaysia we commonly use is risperidone. Okay. So I'd like to acknowledge Ms. Eunice, Ms. Rose Azlin, and Puan Liana, who are all part of the Child Development Center, who all are very involved with all these children and their therapy, and for some of the slides as well. Thank you very much.
Thank you very much, Dr. Juanita. So we are open for Q&A. Okay, for 4 questions. 4 minutes. Okay, sorry, 4 minutes. Okay. 4 questions, 4 minutes.
Good afternoon, Doctor.
Good afternoon.
Actually, my son is 17-year-old.
Yes.
He begins to show depression. So I'm just thinking about starting this antidepressant medication on him. I was wondering, is there any side effect? Or will he be over-dependent on the medication?
No, over-dependence is not a problem. I mean, in adolescents who do not have autism spectrum disorder, sometimes if you use the antidepressants, so what group of antidepressants were the doctors looking at? Was it the one I was talking about, the serotonin-specific reuptake inhibitors?
I'm not quite sure, but the name was Strarata. Was it?
Strattera is not an antidepressant. Yeah?
That is for?
That is for attention. It's atomoxetine.
Attention.
Yes.
Risperidone?
Risperidone is the antipsychotics, the one I was looking at, the last bit, which we use for aggression, self-injury, self-harm. So that's, yeah.
The other one was Luvox.
Luvox.
Is that?
Oh, Luvox is that's maybe, are there any child and adolescent psychiatrists? Yeah. Sorry, would you like to? I'm not familiar. That's a trade name. That must be the brand name. Yes, in the more difficult cases, we do actually involve our child and adolescent psychiatry team.
Because like in KL, where I am renting the practice, they will usually refer to us, the psychiatrist, and we actually do a full mental state assessment first before we subject any child to antidepressants. Strattera is not an antidepressant, neither is risperidone, which is an antipsychotic, as Prof has mentioned just now. That is more for the aggressive behavior. Luvox is an antidepressant, and we usually, yes, we do administer this to children who are older. In your case, I think your son?
17 years old.
Yeah, I think there is indication for that. But if it is started by a psychiatrist, I think it's safe enough to abide by it. Okay, I mean, that's about all I can say because I'm not seeing your son.
Would there be any side effect?
To be honest, any medication has side effects, so don't hold it just to one particular any medication, even paracetamol that we so easily swallow. Okay, yes, this medication has side effect, but it is on a long term. But we're usually very careful on how high the dose we start, and we monitor the child anyway. They are supposed to come up for follow up, and subsequently we see if there are side effects. Either we tail down, or we can switch to another drug if the child really needs the antidepressant.
Can I just give him the medication whenever he needs it, when the mood is not stable? Or
It
something
doesn't
like
work that way, okay? It doesn't work that way. So it's still best to refer to the doctor who first initiated the antidepressant. Please don't be doctors at home. I've got so many mums who does this, especially for ADHD children. On the long term, the child will have side effects because you're creating a very abnormal,
Up and down
yes, the up
intake.
and down things, and the neurotransmitters, okay, then out, and then up, and I think it's best you consult your doctor before you decide to change the whatever the regime prescribed.
So what I'm concerned is, will this medication make him better, or will there be the side effect which is more severe than his present mood?
I'm sorry, Prof. I'm taking
I think you can,
Dr.
I mean,
Fazia, this is Dr. Fazia from Hospital Kuala Lumpur, child and adolescent
maybe you want to
psychiatrist.
see Dr. Fazia afterwards, I think.
Yeah,
Yeah,
I
can we
think,
have one question, last one? Right,
Okay,
sorry.
thank you very much.
Okay, just one last one, because we're standing there.
Good
So this is the
afternoon,
last
doctor.
one, yeah?
Yeah, I have a kid, 3 years old boy. He is a mild autism. His main problem is sleeping problem. He is not hyperactive, but he very difficult to fall asleep, even we given the melatonin, but it doesn't work. Then what is the alternate way or how to help to improve it?
Have you gone through a what we call sleep hygiene program? Make sure that he doesn't sleep for long periods during the afternoon, cutting out caffeine as much as possible.
No, he doesn't take any coffee,
Yeah.
any sugar, or even milk. Also don't have.
In situations like these, what we try and do is we kind of slowly try and change their sleeping time. So let's say, is he sleeping at 2, 3 in the morning or something like that? And then how long does he sleep for? After falling asleep, how long would he sleep for?
Even he doesn't have the nap during the evening, afternoon time. Even we give him sleep on 10, he feel very sleepy, but he still can't fall asleep. That is the problem.
What time does he sleep usually?
Majority we give him sleep around 10 or 10:30.
But what time will he fall asleep?
Or 12 or even more than that.
Okay, so what you want to try to do is try and move his sleep time earlier by about 20 minutes to slowly 20 minutes every day. And every day or maybe every week, yeah? And you want to practice techniques, calming techniques, all the things we mentioned before. Warm baths in the evening sometimes help. You want to make sure that he's not too hyperactive and doesn't do things like watch TV before he falls asleep. Activities which are calming for about 20 minutes before he falls asleep. You can give the melatonin.
Yes.
That works in about half an hour. Yeah. So let's say you intend to. What dose of melatonin is he on? 3. You can actually go up. You can go up to 5. Okay. Yeah, you can. But sometimes with that higher dose, you might have what's called a hangover effect. So they might be really drowsy in the morning and a bit headachy. That's the problem with. But you might want to just increase it for a short while you go through the behavioral and environmental methods to try and move his sleep time earlier and earlier. Okay, but you got to do it slowly, step by step, 20
But
minutes.
sometimes we give him the melatonin and he will wake up in the midnight.
Yeah, the problem with melatonin is it helps you go to sleep, but doesn't always help you stay asleep. Okay, it's just the initial bit. Yeah, so you need to develop coping techniques on what to do when he wakes up. Don't let him do what he likes. Okay, just put him back to bed. Keep putting him back to bed. make sure all the lights are off. So he knows there's no advantage of me waking up. Because what often happens, and what's happened quite a bit with patients I've seen, is the child will wake up and then they do things which are fun, like watching TV, or they go down and eat, or something like that, and it's like a reward for waking. So we want to make it really boring so they have to go back to sleep.
We just don't bother him.
Yeah, so you leave him and he will be doing his own thing. So that's a reward, but you want to actually take him back and make sure he's in the dark room, and so he will fall asleep again.
Okay,
Okay, self-soothe.
I think we have to stop. I'm sorry. Can you ask Dr. Juanita personally? Right, because we have to move on to the other hall. Yeah? So thank you very much for the questions and feedback.